hope you enjoyed your break. And I think that first session set the bar pretty high for us. That was a wonderful session. But I am pleased to moderate this next session on how we can improve routine and seasonal childhood immunization rates in the context of the COVID-19 pandemic. As Dr. Levine and Dr. Vogt highlighted earlier, many children and adolescents across the US are behind on receiving life-saving vaccines. School-located vaccination efforts are one way to promote catch-up of routine and childhood vaccinations. Today, we'll be hearing from 3 experts who will provide a brief overview of the gaps that they are seeing in routine childhood immunization, specific challenges that schools and public health departments face in this area, and how they are working to address these challenges and improve immunization rates for school-aged children and adolescents. Please continue to submit your comments, resources, and questions in the Q&A function on Zoom. Okay, so I am pleased to introduce Ron Balahadia, Immunization Branch Chief for the Hawaii Department of Health, Eva Stone, Manager of District Health Services in Jefferson County, Kentucky, and Judith Schley, Associate Director of the Public Health Institute at Denver Health. And Ron is actually a former past chair of AIM, so I'm really excited that he will be sharing his experience with us. Thank you for all of us for joining. And I will start by asking the panelists to tell us a little bit about their experiences with school-located vaccination clinics. What are the key elements of your approach and what has been integral to your success? So let's start with Ron, who will provide us an overview of his work over the years to increase flu vaccination rates in schools in Hawaii. Ron?
Hi, Claire, can you hear me?
Yes.
Thank you so much. Really appreciate this opportunity. Hawaii has started actually with the school-located vaccination efforts with influenza vaccine. And we've been doing it for over 10 years annually and providing this opportunity to our children here in the state. We actually have been really lucky in how we've been able to formalize and put this effort together. A lot of it really is really important stakeholders throughout our community. So we've really benefited a lot in coordinating these efforts. And it's just been an exciting time, but at the same time, it's really very difficult because it takes a lot of work to get these things set up, planned appropriately, implemented, and then really just going through the process of doing lessons learned and how to improve for the next year. Overall, we've been lucky in that we partnered initially with our insurance companies that help support and subsidize this program for the state of Hawaii, in addition to federal funding that we've were able to secure under our grant, and then other small pockets of funding throughout the state. We start our planning actually early in January, and our vaccinations efforts start in the school setting in mid-October. This gives us an opportunity to plan appropriately, but also at the same time to anticipate any possible issues or problems. And so we've been fortunate enough to be able to handle majority of these school-located efforts through our actual program. We have not farmed out this particular program. It's an integral program within the Hawaii Department of Health Immunization branch. So a lot of effort, a lot of key components, but also more importantly, a lot of support. We have as our partner, our public health nurses that provide our clinic manager setup in each of the different school settings. Of course, the Department of Education is an integral partner with us, and also our private schools and our charter schools. In addition, we partner with a staffing agency that provides us with vaccination efforts throughout. So really a lot of work, a lot of effort throughout. And then also lastly, but definitely one of the more important parts of our school located program are the parents and the children that participate in the program. This is a voluntary program, and even the schools are voluntary as far as them participating in the program. So it's a year-round effort, but an effort that I think we are really glad to have. Definitely a lot of challenges in COVID times. And so we're really trying to adapt and learn as best as we can in doing appropriate distancing and all the mitigation efforts that are needed to minimize any possible exposures. So this is actually a work in progress for us, at the same time learning and trying to share lessons, but also learning from others in what they do. So I'll stop there and then give others opportunity. And if there's any questions, I can circle back.
Thanks so much, Ron. And, you know, you said that it was a lot of work, and I just want to give folks a visual of that. I was lucky enough to be in Hawaii several years ago. We were hosting a Pacific Island meeting, and I got to see Ron's office, and his entire hallway was lined with coolers and boxes to transport the vaccine and materials. And then they had a big open refrigerated section for the vaccine. When he said that, you know, they were taking on doing the vaccine clinics at schools, they were taking it on, and it was amazing how it was organized. Everything was organized by the school, and you know, we just had to walk down the hallway, and it was just evident that they take vaccination in schools seriously. So it is a lot of work, a lot of planning, a lot of collaboration. Let me turn to Eva and have you talk about your work with schools in Jefferson County, Kentucky.
Yeah, so vaccinations is always a big lift for school districts. We've done lots of work in partnership with our local health department and the Board of Health. The Board of Health actually has taken on immunization rates in the past couple of years as one of their objectives because it's become such an issue. When I started with the district, we started a health service advisory council so that we could get some stakeholders at the table to talk about pediatric groups and other stakeholders, advocacy folks, so we could look at immunization rates in the district. Expansion of school-based Medicaid billing, which was reversal of the Medicaid free care rule that CMS issued guidance on in December of 2014, has been a big deal for us. Our school nurses, our district, we've become providers for the Vaccines for Children program because of the ability to bill for those services. And so that's something that states will it depends on their state Medicaid plan. Kentucky had to do an amendment to the state Medicaid plan to allow for that expanded billing, but we think that's going to be an incredible opportunity for us to help address some of the gaps in immunization rates that we have in Jefferson County. And then with the pandemic, we've brought on nearly 100 additional school nurses. And so that will significantly help us address some of those issues as well. Next slide, please. So some gaps that we've noted in the routine immunizations when I started with the district, it was around the time Kentucky required the 2 doses of hepatitis A vaccines. We were one of the last states in the country to have that requirement. And when we started looking at those grades that were audited by the state, it became apparent that there were some significant gaps in immunization rates. So that really prompted us to do a deep dive into our data around immunizations to look at where there were gaps and where our students were not receiving immunizations. And that really showed us some disturbing trends. And that was that nearly 1 in 5 of our children in the district were missing current immunization certificates. And that was nearly 20,000 students. Of those students, almost 92% of those were children living in poverty, and 61.4% were children of color. And so when we talk about disparities and addressing disparities on whether it's my local school district or on a national level, I think it's important that we begin to be able to visualize immunization data and things in the context of the disparities that exist. There were lots of reasons that this was happening, and a lot of it had to do with the structures the setup. We had low participation rate among providers in the city in the Vaccines for Children program. And some of that was because of reimbursement rates. Medicaid in Kentucky reimburses $3 for an injection. And so it was not cost effective for many providers to participate in the program. And then some of the predominant managed care organizations for those children living in poverty had very strict rules about children being only able to see their primary care provider. And if that primary care provider didn't give immunizations, then they were told that they needed to go to the local health department for vaccinations. And at one point, our local health department in the city of 700,000 people had one nurse to administer vaccines. And so those are significant issues when it comes to ensuring that children have access to immunizations, which is likely a big part of the immunization gaps that we have. Next slide, please. And so we've had significant, and we'll continue to have some significant issues to support issues in addressing these catch-up efforts. And one is, as I mentioned, is reimbursement rates for vaccinations. We have become Vaccine for Children providers, so that sounds great. We've got basically 155 school nurses now, and they could be administering immunizations. But if any of you who are back to school with COVID know how labor intensive that work is and the work of contact tracing, and our school nurses are very overwhelmed right now with that work. And that is doesn't lend itself to the situation where they can be administering immunizations. Historically, we've not had communication between state immunization registry and student data system. We're fortunate in Kentucky, we have one student data system across the whole state. And that data system didn't communicate or doesn't communicate with the state immunization registry. So we've fortunately, this has been a big effort we've undertaken throughout the pandemic. And so this past Tuesday evening, our school board passed a data sharing agreement with the state, the Kentucky Health Information Exchange, and we implemented an electronic health record in the district. And so we are now going to have communication between the immunization registry and our electronic health record. Fee-for-service models are challenging because it's not value-based, so there's not big incentive for providers who aren't giving immunizations. And then HIPAA and FERPA is a significant issue in school health in general. There's been lots of talk about school health and things that we can be doing in schools, but HIPAA and FERPA issues need to be addressed. Next slide, please. So some of our major work is to establish memorandums of agreement with our area pharmacies. Again, work with our school-based health centers. We have several school-based health centers. We are shifting our focus to what is the impact of having those school-based health centers, because we have centers in our schools. It's nice to have them there, but if we don't have our compliance in those schools should look better than other schools. And right now that's not what we're seeing in the district, and we'll continue to work to make that happen. And then we've established multiple memorandums of agreement with our area healthcare system and other partners who will also help with the immunization efforts that we are putting in place within JCPS.
Thank you so much, Eva. You've really hit on some of the top challenges, and congratulations on the progress you've made with data exchange and with the Medicaid and recognition as a Medicaid provider and the admin fee. That's incredible. So glad you were able to talk about that a little bit. Also encouraging folks, if you have comments to add on these challenges, please put them in the Q&A. And also we'll now hear from Judith. I'll turn to Judith to talk about an overview of Denver in their school immunization program.
Thank you. Can you go to the next slide, please? So first of all, I want to give a call out to Dr. Tara Vogt. This program started originally with two grants from the CDC that Tara was my project officer on, to actually implement school-located vaccinations and figure out a way to bill for services to make them sustainable. And so Tara, we made it sustainable. So that's a good thing to say. So first I'm going to describe our in-school immunization program. I'm going to highlight the past work we've done with Denver Public Schools, which is the main district in Denver County. And then I'm going to talk to you about planned activities we have for the 2021-2022 school year. Next slide, please. So this gives you an overview of what we've done. We've partnered with the in-school immunization program with Denver Public Schools for over 10 years. They worked with us initially on the grant, and then we have continued with them. Well, we go to schools that do not have school-based health centers. And so what we do is we provide both required and recommended vaccines at schools, irrespective of their insurance status. We do a consenting process where parents consent at the beginning of the year, or the school nurses actually determine that students' needs for compliance issues, certain vaccines, and then we offer all vaccines to them. And it's very nice. We carry private and public vaccine in there. We bring in, a team of people with all the vaccines, and then we do it either on a day, 2 days, or 3 days, whatever is needed. The school district, one other thing in terms of the parents and consenting, if parents, it's an opt-out process for consenting, so that if parents opt out of a certain vaccine, our staff will call the parents and ask them why and try and discuss the reasons why some of those vaccines are important. Required versus recommended, that always gets people confused. Well, if it's required, it must be better than the recommended, and we have to deal with that. We have in Denver, the school district has a very diverse population, and we focus on schools that have what we call low compliance rates and that don't have access to health centers and need help. We do it during the day, and the parents consent prior to the clinics and do not have to be present to it. It only takes about 15 or 20 minutes for each of the students to be in and out of class, which really is much better than a non-compliant student having to leave usually for a half a day or usually even a full day. And we provide all the vaccines and services are billed, but no parent receives a bill for it, but we bill the insurances. Next slide, please. I just want to show a little bit of data. We do middle schools and elementary schools. This is data through 2019 from 2015. Before, when the middle schools, we used to go 3 times a year so we could complete the HPV series. That changed. And so you could see the number of patients, the number of vaccines we've done. We were going a lot to the similar schools or the same schools. And so there was a lot of people that were, had already completed some of them. So we would just focus then on flu. But you can see for the elementary schools, we sort of, except in the last year, and a lot of it had to do, it's always an issue of how to get parents and schools to be engaged in this. And we started some new schools in 2018-19. And so there was a loss. And then 2020 was, we didn't get into schools. We got in there in the fall, but then in the spring, we didn't get there at all. Next slide. And then here you can see over the course since 2012, we've given over 26,000 vaccines cumulatively, which is really showing that we've done a very good job of getting in there. And these are, I could give a slide which shows all of them. A lot of it's flu. Adolescent vaccines are very high also. And then we catch up kids on the MMR in particular. Next slide. And then here, this is what school districts worry about because they have to report it to the state. And so this just gives you a snapshot of 1 year, 2018, 2019, where you can see the schools that we went to, the number of students and what the compliance rates were before we went into the schools. I'm not saying we were the only reason that the compliance improved, but we in middle schools were there twice because of course the HPV vaccine, we want to complete the series. So we really time it that way. And you can see an improvement in compliance, which the school district is very happy with. And then more minimal improvement in the elementary school. Now notice it's one thing to note is we give a lot of flu vaccination and that is not part of their compliance assessment, but that is very important, I think, for mitigating flu spread. Next slide. So what we're planning for this year, we've already started, we just started this week. We're providing all the vaccines required and recommended in the schools, and we include COVID. What we did was we built last year was a DocuSign program in English and Spanish, and it includes all the vaccines, including COVID. So even for our 5 to 11-year-olds or 4 to 11-year-olds, when COVID vaccine is ready, we've got already consents done, and we can then get started. So we're starting with middle schools and moving into elementary, hopefully when we can do COVID too. We give the whole complement of vaccines, and then we have now offered it to parents too. They don't have to be there, but if they want to come, we'll give COVID and flu vaccination. And then I'm going to show in a minute, don't go to the next slide, why a theme of this. I'll show you some data of what's going on with MMR in Denver. And then lastly, we were sort of a separate group from the school-based health centers, which Denver Health runs. So now we have developed a more comprehensive program where we are doing it together with Denver Health School-Based Health Center to enhance it. And we focus on schools that don't have a school-based health center. Next slide. And then this is just a photograph of Denver. And what you can see here is this is MMR completion rates by neighborhood for 4 to 6 year-olds, where the population estimates are the denominator. And you can see that no community in Denver, this is done in June of 2021, no community is at 95%, which is what we need for MMR. And you can see it's on average about 66% as a community. We're going to be going to the schools that are called telehealth pilot, which is part of the school-based health program. And so that we can complement that work where they're going to help school nurses with kids who are sick. Next slide. And I just have one more slide. So in terms of challenges and opportunities, there are a few things, and I think HIPAA and FERPA are definitely an issue, but cost of covering these approaches is hard. We can cover about 50% of our costs with revenue. We're using now COVID vaccination funding to cover all the staffing that's needed, but that's always been a concern in how to really do that. School staff is overwhelmed, and they've always been. A lot of the schools have had 1 nurse per week, which limits engagement. And so that's why we're teaming up with school-based health so we can have more of a comprehensive package of services. And of course, we really know that we've identified risks in community for measles, and we want to use that data to identify the community needs and then prioritize those schools that we can then help improve that. And with that, I've just got my contact information on the last slide. So thank you very much.
Thank you so much, Judith. And thanks to our whole panel. Great to start us off with these presentations. I'm going to start with a question from the audience first. Can the panelists comment on the process for consent and administration of childhood vaccines in school clinics? Do parents have to be present? Is there an age cutoff to administer without parents present? So let me ask Ron to comment on this first.
Sure, thank you so much. So the consent process, we provided the consent forms, and we actually tried to go electronic, but we found that a lot of our really the children that needed the vaccinations the most, oftentimes their parents did not have access to some type of computer or electronic means to be able to sign up. And so we went ahead and just provided both options of handheld hard copy consent form and also an electronic means to register. We found that majority of the parents were very comfortable with having that consent form, filling it out and submitting it back to the schools. So that was our process of getting that completed. They signed off that their child, and again, this is just specifically for influenza vaccines, that their child would be able to provide or get that vaccine. Our program is from kinder to 8th grade. We tried going all the way up to 12th grade, but we found that the higher the grades we went, the less kids were wanting to participate. And so we wanted to focus on the younger kids. And then also as far as parents, they can come and show up to the schools with their children, but majority of them don't. But they all know their children. And so some that are going to be a little bit more anxious or afraid, some of the parents do show up. We don't force children to get vaccinated, even though the parent signs the consent form. We will contact the parent if the child is hesitant and is crying and really is not at a good place. And our nurses usually pull them aside and then communicate with the parent and let them know that we're not going to be vaccinating them. But the parents are not obligated to be there. The consent form does allow for us to administer without their presence.
Great. Okay, great. Thanks, Ron. Yeah, I recall Tiffany telling me that it's easier to vaccinate kids if the parents are not there. But Eva, can you comment on your consent and whether you have parents present?
Sure. With our school-based clinics, it's the same. Parents do not have to be present, but they are certainly welcome to be present. When we did COVID vaccination clinics at most all of our middle and high schools. We did those in a variety of ways. Some of our vendors would not give vaccines without parents present. And so we tried to utilize more the vendors that would vaccinate kids without vendors present. So it just really depends on the provider. But we do not, internally, when we're administering vaccines, do not require parents to be present.
Thanks. And Judith, can you comment about how you do it in Denver?
Yes. So we did paper consents for a long time until this year's our DocuSign inaugural year. But we always had paper, and we still have some paper. I think with COVID, we tried to actually limit paper because it was a lot of pieces of paper that you have to give people, and it's costly to develop. And we do it in English and Spanish, and it's hard for people to store those things. And with whether parents come or not, as I said, parents don't have to be there. We enroll them at the beginning of the school year, or the school nurses will do it. And so then if they want to be there, they can. And we then have a nice team where we actually work with them. We provide like stickers and pencils and things like that to as an incentive for vaccination. And then we always give an aftercare information about the vaccines that we gave, so the parents know exactly what happened. And at the end of the school year, every parent gets a summary of what their kids got for the year, as well as the schools get to upload that information.
Nice, thank you. So this is a specific question for Eva, but I think it's a common one, so I'll ask it. It's from the Q&A. Is the school-based Medicaid billing that you mentioned part of the Medicaid in Schools program? How have either program been useful during the pandemic and getting children caught up on vaccination and wellness visits? I'm not familiar with the Medicaid in Schools program, so I don't know if you can, if you can comment on that.
I'm not familiar with it by that name, but every state has its own name for how they do Medicaid in schools. Prior to reversal of the Medicaid free care rule, school districts could only bill Medicaid for services that were in a child's IEP. And then in December of 2014, that CMS reversed that ruling, that limitation that had been placed there. And so most of the states at that time had to request a state plan amendment. So there had to be, for example, in Kentucky, we had to approach Medicaid, and really there was some advocacy group work with Medicaid to request that state plan amendment that would allow for this expanded billing. So every state sets up that billing. It might look a little different, but basically it allows for billing of things outside of an IEP. And so in Kentucky, it's for any service that's medically necessary. So that includes nursing, but that can include a lot of other services. So that's what allowed us to enroll as Vaccines for Children providers. And really our goal in Kentucky, in Jefferson County, is to connect every school with an entity that can give vaccinations, whether it's a pharmacy, whether it's a school-based clinic. And then we can use our nursing staff to really focus on, we've got about 12,000 students that are enrolled in English as a second language. We have encountered some barriers to our families, particularly those immigrants and refugees, in the past several years have been reluctant to sign up for Medicaid, even though they're eligible, because they've been afraid of the consequences of that. And so what we want to do is focus our nurses on providing immunizations for those children that don't have a provider. And so that's what our goal is in utilizing this program related to vaccines.
Thank you. Do either Ron or Judith want to comment on Medicaid and any role of Medicaid?
We bill Medicaid for the administration fee. We use VFC vaccine and then bill for administration fee. And so that's how we do it. And then we bill all private insurances too.
For Hawaii, sorry, for Hawaii, we've actually been lucky in that we have not engaged in with Medicaid. It's something that we definitely have had on our on the table for discussion, but we've had our insurances and other entities that have supported the program. So we've been looking in that regards, but definitely Medicaid has been a partner of ours, but also at the same time looking at trying to see the mechanisms. As I mentioned earlier, the state program runs this whole operation, so it's a lot of work to try to delve into other areas, but definitely would be willing to learn from others on how best to utilize Medicaid.
And if I could say just one more thing about it. So there's been a lot of talk in this meeting about sustainability. And so one of the barriers to billing Medicaid outside of a school-based health center, because school-based health centers are set up with their own rules. If you're talking about billing within school-based Medicaid, you cannot bill for anything that is federally funded. So for example, in our district, we brought on about 100 school nurses using ESSER funds, and we're not able to bill for those services because they are federally funded positions. We can only bill for those positions that aren't federally funded. So from a sustainability perspective, you know, I would just pitch out there that I hope this is something that the federal administrations will look at and look at perhaps giving school districts the opportunity to be flexible with those billing practices while we're trying to get through the pandemic and build some sustainable systems to help recoup what we know is going to be a huge problem. Our data from Jefferson County shows that at the end of last school year, less than 40% of our kindergartners had their preventive health exam, and 9.9% of our sixth graders had a preventive health exam. And so we know what's getting ready to come with immunizations. These kids are missing, have not accessed the healthcare system, and we need schools and communities need all the support that we can get to get resources to our children where they're desperately needed.
You know, thanks for pointing out that distinction between the federal support and what you can bill Medicaid for. I just wanted to comment a little bit further on that. So I think that Ron's program is a school located vaccination clinic that's not actually happening in school-based centers. So, you know, the public health department is really taking on a lot of that. And in order for them to bill, they have to be recognized as providers, both for the private insurers and in Medicaid. And that's for an admin fee, right? If the public health, or in this case, with COVID, the federal government is providing the vaccine, you're obviously not billing for the vaccine, only for the administration fee. And then in the school-based centers, you know, they have those children, I guess it's Medicaid, enrolled as, you know, patients or whatever, so they can bill for more services. There are no shortage of challenges in all of these. I just wanted to sort of point out some of those distinctions. Okay, well, let's move on to the next question. And this is a question from the Q&A for Judith about your program in Denver. And if you could expand on, and we'll also ask Eva and Ron to join in this one. I think this is a common one. Can you expand on the FERPA and HIPAA challenges that you alluded to?
Sure. So we go in with our electronic health record. I run the immunization program at our health department, and we go in with our electronic health record. We do not have access to the Infinite Campus records for the school district to see what's up to date for a child. We want to know what they've had, because our IIS system might have some things and it might not have everything that has been put into the school records. So we actually had to pay for a paraprofessional to actually be that liaison. We pay for it. That person is employed by the school district, and then they can look at things, and then we can then deal with it. We tried years ago to try and address that with the H1N1. There was a hope that maybe then there would be changes with FERPA, but that did not happen. And that is a true barrier because we're not looking at, we're trying to know individual health information for all sorts of things, just their school vaccinations, so we can give them, we don't over vaccinate, and then we don't miss opportunities. It is a real challenge, and it's costly because we have to pay for somebody to help us.
Thank you. And Eva, do you want to comment on how you were able to make the connections in Kentucky?
Yeah, just so to say a couple things. So the immunization records, we're able as school nurses to access the state immunization registry one person at a time, because HIPAA allows provider to provider sharing of those, those records. FERPA, which schools are under, is a records law. And so FERPA does not allow for immunization records to be shared with another entity, because there's no provisions within FERPA to allow that. So unless I get a specific consent form signed by every single parent in the district, I can't take the records that I have in Infinite Campus, which we also have Infinite Campus in Kentucky, and reconcile those with records in the state immunization registry, because my records are under FERPA and I couldn't prior to this week share them with a registry. So what we've done is we've worked with our state health information exchange. We've created a data sharing agreement that allows us now, that our board enacted, that allows us to share those records. So the state really has set this up in two ways. In Jefferson County, we are specifically having records. We'll be drawing down records from the state immunization registry. So they'll come directly to our district, because HIPAA will allow those records to come to us. In our case, they're going to go to our electronic health record, but other districts in the state who choose to use this data sharing agreement will be able to draw that down their records to Infinite Campus. For us to give records to the registry, we are going to have to do that child by child, but we set up the data sharing agreement so that when the parent signs consent for us to administer the vaccine, then we can upload those vaccination records automatically to the record without somebody have to manually do that data sharing.
Thank you. That's really helpful. And I don't know if you would consider sharing that consent form that you use. I think that would be helpful. These are great to hear, these solutions. So I'm gonna go to some of the questions that we had down for you, because they're really good, and ask you to talk about your have you combined COVID vaccination clinics with other catch-up efforts or flu clinics? Why or why not? And I know, Judith, you talked a little bit about this, but would love to hear more detail on this. I found this fascinating from the last panel. And also, what you are thinking about for 5 to 11-year-olds, please share that as well. Let me go to you, Ron, to kick us off.
Thank you. We actually have not combined efforts at this time. We are planning on trying to do that. It's just one of those things where there's just so many, sadly, competing priorities as we move along and address a lot of issues. But as far as the trying to do co-administration of influenza and COVID, that is something that we are in the works. We have done already COVID vaccinations for our middle school and high school students, and we coordinated efforts with those providers, as was mentioned by Eva previously that want to participate in the program and actually have the Pfizer vaccine, and then the school districts that want to participate, and then make sure that they have established dates of vaccinations. At the time when we did that, that was prior to the summer break. Influenza vaccine was not available at that time, so COVID was the only one that we were administering. As the flu season and influenza vaccines are available and are circling back and trying to get COVID vaccine out to the younger age population, that's definitely something that we're trying to coordinate. Logistically, it's just another added piece that we would need to make sure we coordinate appropriately with our providers to be able to do that. But it's something that we're definitely trying to engage in and see how best to provide that. Over.
Yes, I mean, I think like logistically, it's more than just another thing, right? It's just because of the Pfizer vaccine being so different, the way that it's handled and mixed. So, we'll see what comes with 5 to 11-year-olds. Maybe it will be simpler and the packaging will be simpler, but certainly, yes, it's a challenge logistically too. So Eva, let me turn to you and ask you to comment on what you're planning or doing with COVID and potentially co-administration.
So we haven't done the clinics yet, but that has been our intention. That's what we've been planning for. So the big first step was the data sharing agreement, and then the ability to get those records and have current immunization records for kids. We've worked with getting our memorandums of agreement in place. So for example, we've got one large pharmacy chain that we've worked with, and we've asked them to add childhood immunizations to that memorandum of agreement so they could be included. And then we've entered into memorandums of agreement with some of our large healthcare system with the intention of having them administer all vaccines, not just COVID vaccine. And we've made that ask for anybody who wants to partner with us, that's a requirement for a memorandum of agreement to be giving vaccines in the school. And then finally, we're redoing our MOAs with the school-based health centers that we have that would allow them to send staff to some of our other buildings to also work on providing immunizations for children.
Great. And I'm assuming that they would be responsible for transporting with, for everything from A to Z for the vaccine?
Yes, actually, that they give. And our state has been incredibly helpful in working with us. They're well aware of the issues and challenges we've had and been very supportive in helping to address these things.
Great, thank you. Judith.
So in our consenting process, we list all the vaccines, and now this year COVID too. So when a parent does the consenting, they consent for everything. And then when we go into the schools, we will provide any vaccine they need. And if they need COVID vaccine, we'll give them COVID vaccine or flu or whatever. And we're trying to start with the middle schools first because we can do the 12 and up right now with COVID vaccination. And then when we can go, and then we'll move into elementary schools where hopefully at that time we can do COVID vaccination as well as others. We've been doing outreaches and for all sorts of people and food banks and homeless shelters and that. And now we're doing flu and COVID as we go. And at times we've brought Hep A because we worry about Hep A and things like that in the homeless population. So we're very comfortable giving multiple vaccines. I think initially our work was really about getting COVID vaccine out into community, and we mapped out a lot of places where COVID vaccinations were low, and we prioritized those communities. And so our teams were really good at one vaccine. So we had to train them to do multiple vaccines, and that took some time. But they're very comfortable and they can do all the vaccines. And it's hard when you have a kid that needs 9 vaccines. Let's just say that's a big challenge. That takes more than 15 minutes.
Yes. And training all of the, training your providers on that, having that 15-minute observation period, there's just so much all around. Well, let's talk about your key stakeholders. How have you worked collaboratively with other key stakeholders? So that would include on the public health side, on the education side, the leaders, even your pediatricians. You know, are you getting any pushback from your physician community, from your PTA, you know, everything from A to Z? Let's hear how you're getting that done. This time, I'll start with you, Eva, give you the floor.
Sure. Well, a couple of things we did. First was to establish just a health advisory council with many of the healthcare groups, pediatric groups, getting all those people at the table. When you present the data, particularly some of the data we have, it's pretty hard to argue that the system's not broken in some ways. When 92% of your children who are showing as out of compliance for vaccinations are kids living in poverty, there's a significant health disparity, and 60% of those are children of color. So getting all those folks together just to be open and honest about the data and then talk about the system. And so in Louisville, our public health department really picked up and has been an incredible partner. And the Board of Health even formed a task force. One of our nurse practitioners who's been very passionate, done a lot of work. In fact, she did all the lifting to make sure that we became VFC providers. Is because of that partnership. And then of course, we've had our state support, and then our community health centers and FQHCs, they've all been at the table, and we've just talked about how do we address this as a community. As one of our pediatricians said, you know, this isn't Jefferson County Public Schools problem. This is Louisville's problem. The healthcare system has created this problem. Now, how do we all work together to fix it? And her words are very wise, because all those children are our responsibility collectively. So I feel we've got a very strong partnership in Louisville to help do that.
Judith?
And well, we have a strong relationship with Denver Public Schools. We've had that for many years. It actually is now enhanced because we're teaming up with the school-based health to be a complement to that work, so we can have broader reach to reach more students, and then support them in getting comprehensive care through school-based as well as in through vaccinations with us. They're actually piloting a telehealth program in the schools that we're at, some that we're at and some that we're not, where they can support the school nurses with health related issues, like a kid who's sick and can they stay at school and things like that. So that's a big partnership, as well as with the Denver Health Medical System. We are very much involved in working together to enhance the areas that we want to, where we get communication out that we're going to be doing this work into community. The school district is sending notifications, texts, to push out the importance of vaccinations this year in particular, which has been really helpful for flu and COVID vaccination, which then helps us to go into the schools and the parents are more excited about it.
Thank you. Thank you, Judith. And Ron, do you?
Yeah, definitely within our public health system, we have our immunization program, but our big partners within our program are definitely our public health nurses. They take a huge load for us to be able to perform this program. As you're all well aware, Hawaii's multiple islands, so we have district health offices in each of the different islands that support this effort and are great partners to us. And then also our preparedness program to make sure that they're also involved in the logistics planning, et cetera, on how to ensure that this program operates. We definitely are partners with all of our school systems, not only the Department of Education, the public schools, but also our private and charter schools here in the state. So we definitely have school liaisons with us in this program. Another huge partner is our insurance groups that support and provide monetary money for us to be able to operationalize this effort. Pediatricians, not as much, but they are definitely looped in and informed about the process so that they know the kids that are being vaccinated in the program. And so we provide that information to them, working with our staffing agencies to provide additional vaccinators to help us in the efforts. Volunteers are also a huge part of this process, and parents that are participating and supporting of this effort.
Very, very helpful. And I think in this environment, these suggestions are so good about involving the broader community, having an advisory council, using your parents, involving your parents, using data, kind of just taking the politics out of it. And I think that's very sage advice. You all are making it sound really simple, and I know that it's not. So I'm just giving you a heads up that I'm going to ask you before we adjourn, I'm going to ask you if you have advice for other programs that may be just starting or just wanting to do this about, how to go about this and get to where you are. But there is a question in the chat box that I think is really good. So I'm going to go there now, give you a chance to think about perhaps what might be our last question. This is for Eva, but of course, love to hear from Ron and Judith as well. You mentioned creating an MOU with pharmacies to deliver the routine vaccinations. Are the pharmacies VFC providers? And if not, how is that financed? And how do you coordinate with your VFC as affected you are a VFC provider?
So I will say a couple of things. First of all, before COVID, the pharmacies really weren't interested in partnerships that would involve all childhood vaccines. But there is a way to make it lucrative for pharmacies because they make their money from flu vaccines. So if you can tie your clinics to also administering flu vaccine, then that makes it a little more financially interesting to pharmacies. So that is the first thing I would say. And then COVID is really what made the difference. So in Kentucky in an effort, and this was, before I became very involved in this, but Kentucky allows non-VFC providers to bill Medicaid for kids with Medicaid now, but the reimbursement rate at $3 an injection is not very interesting to most providers. And so that is why I think tying it to something like flu clinics that makes it valuable to them is much more interesting and much more sustainable. So it's not that now what we will do and what our initial model was before COVID was that we would have our staff. We don't ever want to have a clinic and just either be giving vaccines to children with VFC and then private insurance being another group of kids that aren't offered immunizations. We want to be equal. And so our original model was going to be that our nurses, the VFC providers, would give immunizations to kids that had Medicaid within the schools, and then we would use the pharmacies to administer vaccines to kids without Medicaid. But now we have some other options, and so that should not be a barrier for us in Kentucky outside of the reimbursement rate. That's the barrier. If you pay people, they will do it. The issue is them not losing money, which is what a lot of our local providers say. I lose money to participate in this program. And so that's a policy problem that needs to be addressed.
Yes. And I think, working around, it's very difficult to get pharmacies in the VFC program for a number of reasons. So, working around that is certainly a good solution.
And the other challenge was the state immunization registry. Sorry, but COVID changed that. Because COVID, for them to administer COVID vaccine at a pretty decent reimbursement rate, connected them with the registry. So how do we keep that momentum going to change the model?
Yes, I love that. I do love that. One of the benefits of COVID, making these connections with provider data flowing. Judith or Ron, do you want to comment on working with your vaccinators, and are they VFC providers?
I can go unless you want to, Ron, but I can start. So we use our staff to do this, and we have upped our staff because we're doing all sorts of other things, and we've really enhanced all our outreach efforts. And so we are a VFC provider. Our pharmacies are a little different in terms of, there's also a concern, not just, I think, I'm not sure whether our pharmacies in Colorado are all VFC providers. I think they are, but you have to apply and you have to follow through all the federal requirements related to it. But the big thing is young kids and vaccinations by pharmacies. That's not something that pediatric providers have been so keen about. And so that has been a bit of a challenge. And I always think about it as the immunization neighborhood and what we're trying to do, which was talked about in the last section of how we have multimodal approaches to it. And so pharmacies can be one place, but they're not going to come into our schools. And, you know, working with students and little kids in particular, who they don't usually vaccinate in the pharmacies, is a different thing. And so I think we have to be thoughtful about that process. So we use our staff, we train people very carefully about how to work with young kids, because you got a 4-year-old or a 6-year-old, it's very different than a 17-year-old.
Yes.
And so, but we could do it. It's just the pharmacies have never been interested in it. And so, but they can give vaccines in the pharmacies, but they, I think, don't go down to the younger ages, which we want to catch up, especially the 4 to 6-year-olds. We're really hoping that we can get our MMR rates up.
Right. They actually, they technically can, during this public health emergency, vaccinate younger kids, but you know, that's not a sustainable model, and there's always the VFC challenge. Ron, let me hear your words of wisdom.
So for Hawaii, we don't have pharmacies that are in the VFC program, as was mentioned by Eva and Judith. Just the difficulties of reimbursement, and is it lucrative enough for them to be able to provide it. But with COVID, they definitely are vaccinating, and they will vaccinate down to the allowable age via through the PrEP Act down to 3 years of age. They're not comfortable. A lot of them have stated to us, but at the same time, they have that ability to go down to that age. For the state of Hawaii, our statute actually allows pharmacies to vaccinate 11 and up right now, but the PrEP Act actually allows them to go lower than that. It really is, as Judith mentioned, ability to do it on a regular basis and comfortableness, and just ability to vaccinate at that, because it's very different a 4 to 6-year-old than a 17-year-old. But at the same token, I think our pharmacies are being engaged right now. They do provide influenza vaccines to schools that either don't participate and or are having older kids that want to participate in the program, so they go out and vaccinate in those efforts. So I think COVID has changed the landscape a little bit for them, and which is great to hear. And we are trying to get them involved in the VOC program, but with those barriers, as mentioned earlier, it's a little bit more difficult, and hopefully we can get those barriers down.
I hear you. I hear you. Well, I want to thank all of our panelists. This has been a great discussion, and we're not going to have time to hear your words of advice. So if you want to put them in the Q&A, if you have any sage advice for anyone who might be starting out, that would be great, or we can follow up with you afterward.